Thank you for coming to the Learn at Home seminar, Equity in Alzheimer's Disease Diagnosis by Dr. Briggs. Just so you know, all participants are muted upon entry. Following the presentation, you can unmute yourself to ask questions. You can also type questions into the chat box at any time. So I'll introduce our speaker. Dr. Anthony Q. Briggs is junior faculty in the Department of Neurology at the NYU Grossman School of Medicine. And he's a graduate of the ADRC's Rec Scholar Program. Dr. Briggs's research examines biopsychosocial pathways that create accelerated brain aging among racial and ethnic minorities. He focuses on the association between sleep and memory loss, looking at subjective cognitive impairment among Black African Americans, elderly population. So thanks everyone for being here. Take it away, Dr. Briggs.
All right, thank you very much for the introduction, Zena. So good afternoon, everyone. It's great to be here at NYU, Department of Neurology and ADRC. The title of my talk today is An Equity in Alzheimer's Disease Diagnosis. This presentation is rooted in my core statement, is equity really being achieved in AD diagnosis and research? Switch slides. This is a little bit of a delay, but that's okay. So today's learning objectives, we will discuss a couple subheadings. So what we know, what is dementia and the different types of dementia, highlighting Alzheimer's disease disparities by race, ethnicity, and gender, and the definition of a healthy brain aging, risk factors for AD, sleep in AD, health disparities or social determinants of health, and we'll discuss a little bit about my research. So dementia is a syndrome, and dementia is a general term for loss or memory, language problems, problem solving, and other thinking abilities that interfere with daily and occupational activities. Dementia is not a diagnosis, and due to biological changes in the brain. Alzheimer's is the most common cause of dementia. The different types of dementia: Alzheimer's disease, mild cognitive impairment, dementia, subjective cognitive decline, and less common, Parkinson's, dementia, Huntington's disease, and at least about 70 more different types of forms or types of dementia. So on the continuum of cognitive impairment, there's preclinical subjective cognitive decline, which is the focus of my work. And then there's clinical objective mild cognitive impairment, AD dementia, mild, moderate, and advanced. And these are on the continuum. So subjective cognitive decline, which is the focus of my work, is measured through self-reports. So we would, some scholars will use the Cognitive Change Index or CCI, or they'll use actigraphy to measure. And then there's mild cognitive impairment, Alzheimer's disease, measured through clinical cognitive performances and neurological assessments. So in a 2021 Alzheimer's disease facts and figures report, it indicates that there are currently more than 6 million Americans aged 65 years old and older living with Alzheimer's, a number that is expected to be more than double by 2050. While older Blacks and African Americans are 2 times as likely as non-Hispanic whites to have AD or other dementia-related diseases, research has not yet identified a common or standard causes or drivers for this disparity. When we look at the racial and ethnic disparities in AD prevalence, while older Black Americans are twice as likely as older whites to have AD or other dementia-related research hasn't yet identified the etiology and drivers. Higher rates of cardiovascular, heart, and blood vessels disease may play a role, and some studies indicate that after correcting for the overall health and socioeconomic status, these differences disappear. And almost 2/3 of Americans with AD are women. Older Black and Hispanic Americans are more likely than older whites to have AD or other dementias. So what are some of the underlying factors? When we look at the biological factors, they may contribute to these disparities in the AD continuum. As we look at the AD brain, amyloid plaques, abnormal levels of this naturally occurring protein clump together to form plaques that collect between neurons and disrupt the cell function. And then the NFT, or abnormal accumulations of protein, called tau, that collect inside the neurons. Healthy neurons, in part, are supported internally by the structures called microtubules, or which help guide nutrients and molecules from the cell body to the axon and dendrites. When we look at the risk factors for AD, there's non-modifiable. So age, genes, family history, race, and traumatic brain injury. Then there's modifiable risk factors: diabetes, hypertension, depression, obesity, and I think sleep problems, which I'll get into. What is healthy brain aging? Well, healthy brain aging is the absence of symptoms of cognitive decline that can occur well into the 10th decade of life. Older adults with healthy brain aging can still carry out their activities of daily living, lead and live a productive, independent, and happy life. With age, it may take longer to do things, daily activities, or recall information, but it usually comes back. Memory loss is not a normal part of aging, which is a general misconception held by the public. So what is normal brain aging? It is related to gray matter atrophy of prefrontal brain regions, changes that start at age 20 but are masked by compensational mechanisms. White matter atrophy occurs in life and is associated with decreased cognitive performance and executive and attentional dysfunction, cognitively flexibility, focused and divided attention, and processing speed, impaired working, and short-term memory. So neuroplasticity and AD, the brain continues to change in structure and function as we get older. So evidence suggests that older adults compensate for a decline in using different brain areas or by building new pathways. Compared to older adults who perform lower or cognitive tasks, high-performing adults were able to access different areas of their brain in order to compensate for normal aging effects. And as we get older, we may rely more on other areas of the brain, for example, the frontal cortex rather than the hippocampus. So can neuroplasticity be improved? Well, of course, while the way our brains store memories may change as we age, the brain can adapt new ways to recover and compensate for normal memory changes, and even those due to AD. Studies have found that early dementia presents are able to learn, regain abilities, and improve their cognitive functioning. The best way to discuss this is by engaging your brain. Mentally stimulating, challenging activities promote activity and encourage the brain to develop in new cognitive strategies. We maintain the ability to learn and employ new strategies in early AD. Reading comprehension, problem solving, social interaction can help maintain memory and executive functioning. So why is sleep significant to healthy brain aging? Healthy sleep is linked with physical and mental health, and it lowers the risk of type 2 diabetes, heart disease, obesity, depression, stress, attention, a loss of productivity, cognitive decline, and even, in some cases, death. So during sleep, we experience two alternating types of states of sleep over an 8-hour time period: non-rapid eye movement, and rapid eye movement sleep. The cycle repeats itself every 90 minutes. And this slide shows our sleep architecture. The non-rapid eye movement includes 4 stages of sleep. As we shut our eyes for sleep, we first enter the light sleep, which is stage 1, the link between being awake and falling asleep. And stage 2 marks the actual onset of sleep, when you become disengaged from the environment, breathing and heart rate are regular and body temperature continues to go down. We spend about half of our sleep cycle in the first 2 stages. Stage 3 and 4 are the deepest states of sleep, when we experience the most restorative sleep, so essential to functioning. Muscles are completely relaxed, blood pressure drops, and the breathing is slower. During these deep sleep stages, the sleep blood supply to the muscles is increased. Energy is restored, tissue and growth repair occur, and important hormones are released for growth and development. Rapid eye movement sleep occurs increasingly over a later part of the night and is also necessary for providing energy to our brains and body. During the rapid eye movement sleep, our brains are active and dreaming occurs. As we enter REM sleep, our bodies actually become immobile, muscles shut down, and again, we are relaxed. Breathing and heart rate may become irregular. And during this stage of active brain activity, the eyes dart back and forth under the eyelids, giving REM sleep its name. Because getting enough REM sleep may contribute to memory consolidation, it is especially important following a learning experience. REM sleep typically comprises of a quarter of our night. Sleep needs vary over time. Overall, sleep changes over time. Most adults need approximately 7 hours a night, 7 hours of sleep per night. And generally, people are getting less sleep due to increased work, environmental factors, whether that be excessive light exposure or excessive noise pollution, and is working doing shift work. And so when we go through these, or when individuals go through these, sometimes they may think that, you know what, I'm not getting enough sleep. Maybe I can catch up on sleep. But the idea is that you can't really catch up on sleep. Temporarily, you may feel rejuvenated, you might feel relieved, but there may be already changes going on physiologically that are irreversible due to the lack of quality sleep. Sleep in older age. Older people tend to go to sleep earlier. They may also experience more fragmented sleep, decrease in sleep quality, less deep sleep, stage 3, wake up more often during the night, increase in the prevalence of sleep. After age 60, nighttime sleep tends to get shorter and lighter and more interrupted by multiple awakenings. And as we age, the way we encode our memories and learn changes as well, such that changes to our sleep don't always negatively impact how we store memories. However, some learning functions improve with sleep, suggesting that it is still a vital physiological process governing aging and cognition. Sleep and memory. Sleep is a time when things learned during the day are stored for the long term. And this is done most efficiently when the brain is less busy processing external information. Less sleep, equals less capacity to form and consolidate memories. A group of sleep-deprived people record 40% of fewer words on a memory task as compared to non-sleep deprived people. Sleep in AD. Well, Alzheimer's patients have more sleep disturbances, get less sleep overall. And sleep disorders are highly preventable in AD, or prevalent is the word. Chronic sleep deprivation has been associated with the accumulation of amyloid plaques. It's a two-way street, or some may use the term U-shaped or bidirectional, but the deterioration of the brain regions and neural connections results in poor sleep. Poor sleep can contribute to cognitive decline. Sleep in AD. In the earlier stages, it may may sleep more than usual or wake up disoriented. Mid stages, it may sleep during the day and awaken frequently throughout the night. More advanced, rarely sleep for long periods, rather they doze irregularly through the day and night. And severe, complete reversal of the usual daytime wakefulness, nighttime sleep pattern. So how do we nurture healthy brain aging? Well, the ultimate goal really is, in order to do that, there's some protective factors that help with that. Cognitive education, cognitive activities, things like reading, exercise, social activities, health, diet, social networks or social connections, use of available resources, living purposeful lives, and getting an adequate amount of sleep. Health disparities. So in thinking about the association of sleep deprivation and cognitive decline, my research specifically, preclinical dementia, preclinical subjective decline, it is important that social determinants of health or understand that that it can be a contributing factor to sleep issues and cognitive decline. So these factors can be socioeconomic positions, education, income, occupation, gender, identity, stress. Stress, anxiety, depression, or racism and discrimination. Now, there's a professor by the name of Lisa Barnes at Rush University who has done some work on brain aging, particularly on Black Americans who have experienced the Jim Crow laws and segregation. And she has monitored these patients and their brains and brain health over time, and has seen that some of these individuals there is an association of segregation and racism and discrimination with cognition or cognitive decline or dementia. So there is some studies that are out there, but this is just kind of put that out there. Then there's access to quality in healthcare. Do you have access? Do you have insurance? Do you have somebody to take you to the physician or healthcare provider? All these things to consider. Social cohesion, connectivity. Do you have a community that you can go to that you can be engaged, where you have community engagement, that you can have some type of stimulation? And then there's neighborhood conditions or zip codes. Very interesting. You have to, when it comes to this, you have to think about where are you situated geographically and in your neighborhood. Does your neighborhood have excessive excessive noise pollution or poor air quality? Do you have access to green space? Do you have access to transportation? And so all these other factors that might be attributable or contributing to poor brain health and then cognitive decline. So my research work, my overall objective is to better understand the characteristics and the etiology and drivers of preclinical dementia in Blacks, African Americans. So my first aim is to examine the cross-sectional association between sleep duration and subjective cognitive decline in community-dwelling older adults. And my hypothesis, as I mentioned, in terms of the U-shape, sleep duration will have a U-shaped association with subjective cognitive decline, such as older adults with shorter or longer sleep duration will have a higher risk of having SCD. Aims 2, examine whether racial differences exist in the association between sleep duration and subjective cognitive decline. And my hypothesis is that African Americans with shorter or longer sleep duration will have higher rates of SCD compared to non-Hispanic whites counterparts. Not sure why it is like this, but anyway. To aim 3, to ascertain that the effects of influence of social determinants of health factors and the association between sleep duration and subjective cognitive decline. And my hypothesis is that the social determinants of health, the factors such as socioeconomic status, educational attainment, environmental factors, neighborhood conditions, zip codes, light, noise pollution, access to care, limited access to green space, will have a greater unique and potential additive effects on the associations with sleep duration and subjective cognitive decline in Black African Americans. My approach, I'll use a cross-sectional analysis, and I will identify 50 individuals, 25 African Americans, 25 non-Hispanic whites from the NYU ADRC clinical core database with the following criteria: cognitively normal, in both demographics, over the age of 60, they have completed actigraphy and have no issues, and they have no issues of sleep apnea or other sleep disorders with insomnia. The methodology, I'll use subjective cognitive decline, cognitive change index, 20-item self-report scale, and I'll use actigraphy will be used to obtain data from sleep duration and sleep quality, bedtime, wake time, after sleep onset awakenings, and number of awakenings, total sleep time, and sleep efficiency. And the measure, in order for me to measure the social determinants of health, psychosocial risk factors, I'll use a perceived stress scale, everyday discrimination scale, major experiences scale, and access to health services scale. My innovation is this proposal will also build upon their scope by carefully identifying and examining drivers of SED in Blacks cross-sectionally, as well as examining the short-term outcomes longitudinally. This will contribute to the ultimate objective to developing preclinical, cultural sensitive, and preventable intervention at the personalized community and population levels. Thank you for listening to my presentation.